Hello there! In this video, I'm going to slowly guide you through this entire unit. It's actually a re-upload of a live stream that I made in the run-up to the 2025 exams. But you can follow along with me as I spend a few hours filling in this A3 poster. As it's a live stream, I respond to questions given to me by hundreds of real students as they prepare for their exams. I have 7 of these live streams that I've re-uploaded, and over the course of this year, I'm going to host the remaining live streams. And re-record the old ones so you've got a chance to take part. If you want to join me, then please subscribe so you get notified when I announce one of these live streams. It would also be great if you could subscribe because I just hit 94,000 subscribers. So pretty close to that 100k milestone. So if you're finding my stuff useful and want a free way to help out the channel, that would be amazing. Now, I don't do sponsorships for things like VPNs, but the other things I make are entirely focused on helping you get the best out of your A-level. And selling all these things helps you make the free content on YouTube. You can get this poster and posters for every unit, both completed and filled in as digital files and now as a revision book. You could also follow along with each of my main videos with worksheets. These are designed to give you an active role and make the information sticky. I also have an app for you to test yourself, and I let you use all the paper 1 for free without ads before you decide if it's worth unlocking papers 2 and 3. Altogether, it's thousands of pre-made quiz questions and flashcards. And I have over 17 hours of exam question walkthroughs, as well as lots of other resources over on Patreon. And starting now, I'm going to be doing an exam question focused live stream most weeks that are exclusive to my Patreon supporters. Thank you for listening to all of that. Let's get started. Let's do this, everyone. Let's start off with deviation from social norms, and let's start off with the AO1 for this. What things are we saying are true about the deviation from social norms definition? So yeah, if you're watching the recording of this, you're going to want to maybe try and guess what I'm about to reveal, or you might want to wait until I reveal it and then note it down neatly. Okay, we've got behaviors that go against the unwritten rules of society from Zakia. That's good. Strays from social norms, behaviors are rational, unacceptable, and desirable. So yeah, unwritten expectation of behavior. Okay, we've deviance. We've had the word deviant as well. Okay, I think we've had most of what I have put in, but not quite all. So hopefully some of this will be helpful for some of you. Second. Let's just hide this a second because I want to do the evaluation separately. Sorry about this, guys. I just realized that I didn't hide the evaluations on the slides, and I want to do the evaluations separately, but that will come up next. So maybe a second. Yeah, it's taking a little second because I have to do this for all 4 of them, but I'm on the last one now. And that, everyone, is done. There we go. I'm back. So what I've got is unwritten behavioural try that again. Unwritten behavioural expectations. And they vary from culture, also time, and also context. The concept, which a bunch of you did have, not massive number of you, was social deviance. So these are the individuals who break the norms of their society, and they're the ones that are seen as abnormal. We can also mention it has high cultural specificity. Yeah, I'll go with that. So, there's a variation in different cultures about tolerance to homosexuality, religious experience, and public displays of emotion. So, yeah, that is deviation from social norms. Let's do some evaluations, everyone. Just give me a strength or a weakness, and we'll get this together. And if you mention something that I don't have myself, then I will shout it out. So Bianca's already got a weakness, is that social changes are not fixed, they change over time and vary from culture. You want to explain why that's a weakness? Cultural relativity, lacking temporal validity, strength. All countries have different definitions. There's a term that I want linked to that. Maybe we might have a term linked to that. Does not impose, very nice, Susanna. It does not impose a Western view of abnormality on other non-Western cultures. Got not objective. Flexible. Can lead to the abuse of human rights is a really good point, Annie. It's not what I'm going to go for, but it is an interesting one to dive into. Did you go with the same one? Okay, thank you very much. The ones that I have got and just built out just a little bit more is the concept of ethnocentric. So it's not based on any one individual culture because it is dependent on the on the population that's there. Okay. So the weakness is people who move to a new culture might be seen as abnormal. So if we're deviating from social norms, we have the issue, and I think a lot of you might have taken this from schizophrenia. If you are from a Caribbean background and you move to the UK, you're 7 times more likely to be diagnosed with schizophrenia. I wonder if anybody knows the reason for that. Anyone knows the reason why? As you think about that, and feel free to type it in, we'll move on to the next section, which is failure to function. Let's go for the AO1, everyone, for failure to function. Category failure from Hosanna, that's good. So yeah, if you write failure to function for me. Yeah, we got some people talking to me about the question about people from Afro-Caribbean heritage. The hearing voices is often a cultural experience. And you might see that as quite abnormal, but there are some religious organizations in the UK who speak in what's called tongues. But that's a religious experience and wouldn't necessarily be seen as a way to classify abnormality. So, yeah, very good. Let's go with the AO1 for failure to function. And what we have is an inability to cope with day-to-day challenges, and a day-to-day challenge, as an example, might be keeping up with personal hygiene. Everybody I saw that had that. Rosen and Seligman's features, there's a little bit more to go off on here, is we can include maladaptive behavior. So maladaptive is often a term that is misunderstood. So it basically means going against your own best interests. So they're often irrational, unpredictable. We can also add personal anguish and observer discomfort. There are more elements to Rosenhau and Seligman's features, but I don't think we necessarily need all of them if we've got that. Okay, let's go for some evaluations then, everyone. What are some evaluations for failure to function adequately? I've combined and summarized from my psychopathology. Sorry about that, guys. My mic died on me there. So yeah, what I've got as an evaluation there is respects the individual and their own personal experience, unlike the statistical and frequency and deviation from social norms. But also only includes people who can't cope. And we have a bunch of people who we might expect to want to define as abnormal, but these people can cope, and that would be psychopaths. So you could even argue having low empathy actually helps them, but at the expense of other people. Okay. Let's go with statistical infrequency. So there we go. Give me some AO1 knowledge of statistical infrequency. What are we basing this definition of abnormality on? Not much we need to include in here, but there's some things that we might want to. I do like Kazana's evaluation for failure to function about the subjectivity on there, so you can feel free to add that one on as well if you wish. Okay, so we've got some stuff in there for statistical infrequency. We've got the normal distribution curve based off that. Extreme ends of the normal distribution. Normal range. Some people talking about 2 standard deviations. IQ tests would be a great example. Behavior is rare within the population. Okay, yes. Less than 5% of the population. Okay, so there's some really good stuff there. Everything that I've got. So abnormal of mental condition is rare in the population, rarity judged by statistics. So if we compare the normal distribution curve, compare an individual to normal distribution curve, people talking about 2 standard deviations out, which is pretty cool. But even without an extreme end, then we would see those people as statistically abnormal. And probably the best example we can give is intellectual disability disorder. It's not its only criteria, but one of the criteria is an IQ 2 standard deviations below the mean, which would be 70 IQ points. So that's a very small proportion of the population, 2%. So if we can talk about abnormality as unusual, that would work. Okay. So I've just realized something in my digital file. I accidentally copied across 2 evaluations from deviations from social norms onto the screen. So they won't appear right, but we can still talk about the evaluation of statistical infrequency in the chat, and I'll say it out loud as well so we can fill that in. I'll fix the digital file a little bit. So give me some evaluations, please, of statistical infrequency, positives or negatives. Do you get time to copy this down? You're welcome to pause me, but you won't be able to keep up at real speed. I'm going to try not to go too slowly through this because I know people find 3 hours a long slog. So yeah, your choice. It will be online for 24 hours. Okay, people with high IQ statistically abnormal, but it is desirable. That's a great positive evaluation. It's not always not desirable to have a high be outside of statistical means. Yeah, OCD is a great example from Grace. Well done. OCD is defined as statistically infrequent, and it's 1% of the population. But it wouldn't. But depression would not, as it's 17% of the population. So it may not get treatment as they need, as it's not abnormal. That's a great example of a common mental illness that we would hope to treat people for. Okay. Two objectives. Some people may fall just outside or just inside. That is also a good example. And sometimes very serious decisions can be made on just one or two IQ points as well. Okay, we got some really good ones there, guys. Apologies that the digital file wasn't copied across correctly. I will fix that, but the ones that I've read out and the ones in the chat are really useful. Okay. So let's go on to Jehoda and deviation from ideal mental health. So if people can give me some AO1 points here, what are we going to talk about if the essay is about deviation from ideal mental health? Now, you've noticed I've not done a massive amount of points for each individual definition. We've only seen this as a 16 marker when we can talk about two. I would assume that would be the case going forward. So, you know, we're trying to get about 3 points worth of AO1 knowledge out of this. So what have we got? So right to talk about this is Jehoda's theory. We've got 6 criteria. We have a artistic aura for the first person to get them out. Well done. Environmental mastery, autonomy, resistance to stress, positive self-attitude, and accurate perception of reality. And we've also got the fact that it not meeting the criteria is the way that we define abnormality. Trying to reach self-actualization, got in there as well. Excellent. Okay, let's have a little reveal of that. If you're writing this down, humanistic as well. That's the theoretical basis. Yeah, very easy to remember with ESPAR. These 6 features that we've got on there. So we have got the AO1 for deviation from ideal mental health. Let's get the evaluations in there, guys. What have you got for me as evaluations? I think you could probably remember all 6 of them relatively easily. And there's not a lot else to talk about for a deviation from ideal mental health. So you might as well try and remember all 6 of them. ESPAR is a good way to remember them. Okay, Grace is in there quickly again with a really good evaluation. Feasibility, due to the criteria found by Jehoda, makes ideal mental health, normality, practically impossible to achieve, so the majority of the population will be considered abnormal. That's well written, Grace. Okay, let's see where else we've got in the chat. Okay, we've got a holistic approach as well, is what we might go for as a positive. Yeah, a lot of people going for the criticisms there, so hopefully we have a vague understanding of the positives as well, because we may say it's a potentially more valid way of defining abnormality. So it is holistic. We had a big conversation yesterday about the differences between reductionism and determinism, and what reductionism was and determinism was. I don't want to dive into that again, because I know probably most of the 300 people in this chat were here yesterday. But you know, because of the number of different variables going on here, we will talk about this as a holistic definition. We are also not just defining abnormality, we're suggesting how to become a better person. So there is also talking about how issues can be overcome. And as pointed out and written better by Grace than by me, I have to say, the criteria are too strict. So it is very challenging to achieve all of those 6 requirements. So most people would be defined as abnormal, which is not really what you want from a definition of abnormality. Okay, that is definitions of abnormality. Let's go in now to characteristics. So, of course, we need to know behavioral, emotional, and cognitive characteristics of each of the disorders that we're going to cover in this unit. I'm just going to have a little look to see if anyone's got any random questions for me before we begin. If you are wanting to type something into the chat, I would like you to type in what are the behavioral, emotional, and cognitive characteristics of phobias. You have to go into it in detail and bullet point it for me. I'm not. If you know something else, Luna, that will be able to get you AO1 points, then feel free to use that instead. But if we're talking about the features of ideal mental health, the definition is deviation from ideal mental health. So we probably would want to know how ideal mental health is defined. So I probably would try and remember them, but that's up to you. As you're if you're just listing them, probably all of them, Lily. If you were going to go to details about, say, what self-actualization is, you can have fewer. Okay, there we got some good things, everyone. So we've got avoidance and panic. Okay, we're not necessarily listing them out in types, but yeah, Louisa, behavioral avoidance and panic. Reduced cognitive capacity. Luna, that's a really useful little mnemonic there. P6FAR. Okay, let's have a look at what I've got then. So under behavioral, so be careful with this section. Think carefully about what is a behavior. So when it comes to behavior, we should see a physical change within that person and the way they do things. It has to be a very physical response. So if we're talking about behavior, to adapt your normal behavior to avoid a phobia is a physical thing that we could see. You know, we could see someone walking across a road, for example, to avoid a bird. That's behavioral. Panic. So it's not the emotional element, it's the physical element. So we've got a physical response like screaming and running away. Failure to function. So we're avoiding what makes it difficult to do, avoiding the phobic object would make it difficult to do a task. So let's say if you need to drop off a letter, but you had a phobia of birds, and you had to go back home because you saw a bird when you came out, you would fail to function in that task. So it's all physical things. Emotional is anxiety and fear. So an uncomfortably high state of mental arousal is anxiety, and fear is intense, and the idea is it only goes away when the phobic object has gone away. Cognitive would be irrational thoughts. So we've got an exaggerated belief in the possible harm that could come from that phobic object. And also under cognitive, we've got reduced cognitive capacity. So we're not able to think as clearly because of this focus on the phobia. Let's move on, everybody. Let's move on to characteristics of let's go for depression. Behavioral, emotional, and cognitive. Please label it B, C, or E when you type it out. See if we've got anything else in here. Yeah, a few people have got some other ones. That's absolutely fine. Some people have got cognitive distortions. I've only seen this, I know I'm going to be wrong, in very small mark questions, sometimes even multiple choice, but be difficult to use for anything else. Blue Hand, I think it would. Okay, we've got some more in there that I've not included, but would be acceptable. There's quite a range of behavioral, emotional, and cognitive characteristics. We don't need a massive number, but we definitely need some for each. Okay, let's go with the behavioral, emotional, cognitive characteristics of depression and see what I've got. So behavioral, we've got a reduction in activity level. We can also call this lethargy, and we've got low energies for tasks. We've got a change in eating behavior. So a change in eating behavior can either be weight gain or it can be weight loss. And we've also got aggression. Now, this could be aggression to other people, but obviously this could also be aggression to people, to themselves. We've also got emotional characteristics. So sadness would be a persistent low mood, and guilt would be a feeling of helplessness and a sense of low value. And then cognitive, we've got poor concentration. We can't give our full attention to tasks. And then we have also negative schema. So we're going to pick up on this a little bit later on in the depression, go into more detail there. But we've got a cognitive issue of automatic negative bias to the world, the self, and the future. So just keep in mind of getting these the right way around, especially with behavior as well. Okay. We're going to have a go at our last characteristic. We're going to go for OCD. So have a little throw of behavioral, emotional, and cognitive characteristics for OCD. Okay, first in there with Grace, OCD behavioral. You've got rituals, emotional, fear and anxiety, and then cognitive, we've got irrational thoughts and obsessions. Blue hand straight in there as well with compulsions as B, so probably the typical thing we would expect to see talking about the behavioral characteristics of OCD. Excellent. Isolation, Celeste? I'm not sure. It depends how you'd say it. Possibly if we're avoiding triggers to our obsessions. Okay. Hypervigilance is a great one there that IJ has put down. An unnamed gamer. Let's reveal what I've got here so we can write it down. There we go. So behavioral, we'd expect to see compulsions. So these are the behaviors that are performed repeatedly to reduce anxiety. And then we've also got, as some people put in the chat, avoidance. So we're adapting our normal behavior. It's a different situation here than with phobias. So we're trying to avoid triggering obsessions. So maybe if you have an obsession about cleanliness of a kitchen, you might avoid actually using the kitchen and making food because you know that when you've made food, you'll have a contamination fear. Next up, we have an emotional. So obviously, OCD is an anxiety disorder, so an uncomfortably high state of mental arousal. And we also, because of the effect that it's having on the individual's life, we're also linked to depression as well. Cognitive, we have obsessions. So these are intrusive, irrational thoughts. These intrusive, irrational thoughts are also generally unpleasant, and they're catastrophic, as in they always go to the worst possible outcome. Next up, we have obsessions so we have hypervigilance, which a few people put in the chat. So this is a permanent state of alertness, and we're looking for the sources of those obsessions. Okay, so we got a couple in each, which should help us with any question we get asked on in that section. Okay, so we're about to do phobias. We'll do phobias first, and then we'll take a 10-minute break, and then we'll do depression, and then we'll do OCD. because I know that some people are writing as well as we go. Guilt and disgust, yeah, if you have a way to explain the justification for them, you can use those as well. Awareness of irrationality would be under cognitive. Selective attention would also work. Okay, so we are in phobias, everyone. We are in phobias. I'm going to break this down just a little bit and reveal it a little slower. What is, very briefly, what is the two-process model? Okay, who can give me a two-process model? So we've got some of the classical and operant conditioning. So classical and operant conditioning is correct, and we are going to go into that, but kind of more fundamentally, although people have included it in their discussion, it is the two-process model described how phobias are acquired and maintained, and as we're going to go into, by operant classical conditioning. Just be very careful. Sometimes this term, the two-process models, throws people a little bit, and they don't automatically click about the classical operant conditioning, although everyone who's put in the chat has done well, so I'm sure you guys will be fine. So let's start with acquisition then. Acquisition and classical conditioning. Can somebody give me a dive into what classical conditioning means in the context of phobias, please? I can turn off the slow chat if you want, but if it gets too wild, I think I might put it back on. I'll put it down to 10 seconds so no one can actually just wildly spam. If you're going to discuss research into a theory, you would generally include it as AO1. Although research can mean theory or the study, but if there's research into a theory, you'd be expected for the study. Okay, so we've got Luna acquires through association of a neutral stimulus a phobia of an unconditioned stimulus, something like pain. We got a little Albert study as an example there. Okay. We got some good terminology there, some good use of the abbreviations. If we're going to write it up, we're obviously going to want to put in the full terminology before we use the abbreviations. But writing this in short, a phobic object will change from a neutral stimulus, so it has no fear response, to a conditioned stimulus, which then at the same time is unconditioned stimulus that causes fear. So yeah, we can place in some examples there, and you guys using the little Albert case study is useful. We wouldn't want to mention Pavlov, I don't think, in this point. There's a lot of other things that we're going to have to get through in this essay, and so to bringing it all back away to Pavlov would be problematic. If I was you, I'd give an example. We don't have space for it in the poster. Maybe give an example of a phobia. Like say one to balloons and the sound of popping and the fact that popping causes the loud unexpected noise will trigger a fear response on its own. Okay, so let's go. You guys did really well acquisition. Let's go into maintenance, everyone. How would we talk about phobias being maintained? So yeah, it's very easy. I know what you said about Pavlov, but it's very easy in psychology essays to go off on a tangent and talk about something that isn't directly relevant, even though it kind of makes sense. But yeah, the little Albert study would be much better, and to bring that in as an evaluation is not one that I've used, I don't think, but it would be useful. Okay, really good one there from Grace899. The avoidance of the feared stimulus reduces feelings of anxiety and is therefore negative reinforcing. That's really good. It's about as good as what I've written in there as well. Phobia is maintained via operant conditioning. The avoidance behavior negatively forces the phobia by avoiding the negative feeling of anxiety. Kara, that is really good. Okay, so we think about if we got an essay in this, a 16 marker, we need about 6 marks. We're probably taking a couple of marks from acquisition, a couple of marks from maintenance. So let's have a look at what we've got for maintenance. Avoidance behavior leads to reduction in anxiety, which is pleasant, which acts as negative reinforcement, strengthening the phobia. So about what a bunch of you put down. Well done for typing that in. Joe, I think the number of AF3 points recommended for a 16 marker vary significantly depending on the student. If you go and watch the essay writing video I did about 2 months ago, it'll go on a deep dive for you personally, how many you should have in there. It's near the midway through. Okay, let's go for evaluations, everyone. I'll just reveal all of them, so bullet point me as many as you can. Positive and negative evaluations of phobias. I'll pick some of them up from the chat. But let's have a little look at what we've got for evaluations. Again, I think there are better evaluations than Pavlov to use for this section. So yeah, you want to try and make the evaluations as relevant to the section as possible. Okay. So let's put in systematic desensitization. We can talk about the treatments as evaluations. We have to be very, very, very careful about it, but it can work for you. Okay, Hosanna and Grace coming out at the same time with the Watson and Rayner one. I'll read Hosanna's because I picked up Grace a few times. Watson and Rayner, 1920s. Little Albert, behaviorist theories of phobia, acquisition, and maintenance have been applied to develop counter conditioning therapies. So we've got 2 there. A little more deep on Watson and Rayner. They made a loud noise while he looked at a white rat, which then provoked a fear response to all small animals. That was a good summary. Yeah, research evidence as well. Okay, let's have a little look at what I've put down. It's very similar to what you guys have put into the chat. So yeah, Watson and Rayner gave little Albert a phobia of a rat using association, brackets, loud noise. We have to pull that apart a little bit in order to make it work, but obviously this is a summary posted just to trigger our memories. This video will be saved. It'll be on YouTube for at least 24 hours, but then it'll disappear and go to a Patreon only playlist when it's replaced by the memory live stream. So I have got a piece of research as well, one that other people didn't use. Some other research out there, which is really well done. Donado, so conditioning events, dog bites are as common in people without a dog phobia. Actually was higher, but not maybe statistically significant, 66%, as with 55%. So if we're arguing that phobias are due to these associations, well, actually people without a phobia have associations as well, and it doesn't lead to a phobia. Okay, let's go. We also have this element of each of the explanations can be positively evaluated by the fact that they led to effective treatments. Now, let's just make sure that we actually get this right, though. If we are using a treatment as a positive of the explanation, the reason that we're using it is because if the treatment is effective, that improves our trust in the validity of the underlying theory. We don't want to just say, oh, the treatments work. What's the point of mentioning that as an evaluation? The point of mentioning that as an evaluation is to bring it back and say, well, if the treatments work, that means there should be some validity to the underlying theory. Remember, the essay is about the theory. if it is if it is about the explanation, not the treatment. So yeah, just be very careful. And one evaluation I think is really useful is we do have phobias for quite unusual things, really. You know, like snakes and spiders. Like I don't know if anyone has a spider phobia, but I don't know how often you see a large, scary spider. And even more so, like how often have you been bitten or hurt by one? Um, they're quite unusual. Phobias to things that do hurt you, though. How many people have accidentally cut themselves with a knife in the kitchen, which might really hurt themselves, might be a bit shocking. Phobias to knives are very, very rare. So the things that actually hurt people are less rare as a phobia, or more rare as a phobia, which goes against this this association argument. Um, Yeah, so there's an argument that actually someone's got their biological preparedness theory that actually has evolutionary basis. Here's a wild one. I won't spend too long talking about this, but it's kind of interesting. Um, and that is all around the world, you have these legends of scary animals that in different societies that seem to be disconnected, and they often have the body of a snake and the face of like a tiger and the wings. So obviously that's the legends of dragons. And you feel, well, why is the scariest monster that? And then you think to your evolutionary ancestors, the things that preyed on us most when before we were human would have been tigers and big cats, eagles and snakes. So if maybe it's a amalgamation, maybe it's a combination of all of our scariest predators. Anyway. Oop. There we go. I'm back in frame. Can stop shifting around. All right. Let's go. We're going to go to treatments now, everyone. We're going to go to treatments. I'm going to break this down a little bit. I won't dive through it too quickly. What does it mean, everyone, to counter condition? This is the fundamental element of both of the treatments. So, what does it mean for counter condition? I got someone straight in there with a really good term. Hosanna, reciprocal inhibition, using two antagonistic emotions, fear and relaxation, to counter condition remophobia. So anyone who doesn't have that term reciprocal inhibition, maybe note that one down. Got unlearn, replace the conditioned response. Two opposite emotions cannot coexist. Really good work, everyone. Let's have a look at what I've written and what might go in your poster. So counter conditioning is replacing the fear association with relaxation. Reciprocal inhibition is the idea that opposite emotions cannot coexist. Both of the treatments are based on this principle, but they have different ways of going about it. So as a brief summary, how are we going to write down systematic desensitization? So give me systematic desensitization, everyone. So don't worry if you don't get all of it. We'll try and put it together with everyone's responses. So we've got Luna coming in there with systematic sensation includes a hierarchy of fear to work through the therapist. Unknown One was the first person to come up with the element of relaxation being a key element of this. There's definitely going to be something to distinguish it between the next one, which is flooding, is that relaxation. Okay, who's ended with a really good example. Therapist begins by teaching the client relaxation techniques. That is true. That's how we would start. Then they create an anxiety hierarchy together, and they're exposed to each level and the whole the phobia object. And I think the first person to mention this, sorry, I'm not able to say her name right, Nini D3U, a important element I think people often miss is you need to relax at each stage of the anxiety hierarchy. You can't rush through this. It's not just learning the relaxation, it's the pausing at each stage until the anxiety goes away. The fear hierarchy is from release to most feared stimulus. So a bit more of a development of that, Bianca. That's good. Okay, we've got some good answers there, everyone. Good work. A really nice summary there from Eve Furness as well. I've written systematic sensitization, anxiety hierarchy from the least feared presentation to the most, use of relaxation techniques, breathing exercise, putting in each stage. And we don't have much space there to put in. We make sure that we relax each stage. And then the idea is a gradual exposure will lead to, and there's a term that we've not used yet, is extinction. Extinction is when we would have lost the fear response. Okay. Let's go on to the next one, which is the fun one. Let's go into flooding. So please, everyone, can you give me a definition of flooding? Okay, some good definitions there. So flooding is where you're just exposed to the phobia and eventually you'll calm down during it, usually through a breathing exercise to create reciprocal inhibition. Yeah. Okay, we've also got maybe a little bit more in-depth one there from Grace. All at once and for a prolonged time without any gradual build-up. So we're trying to build a distinction there between systematic and flooding, and I think that helps a little. Still, needs to use relaxation techniques. The Amani element there, no avoidance allowed. To allow avoidance would be to maintain the phobia. The reduction of anxiety by being removed from the phobia would strengthen the phobia. Okay, some good definitions there, Tabia. Flooding is a complete exposure to phobia in one long session in hopes that anxiety levels will eventually have a drop off, so an individual is able to relax with the phobia. Excellent. I think we're good with our definition of flooding there. So let me reveal mine. So an immediate full exposure to a phobic stimulus, temporary panic. Panic will pass due to exhaustion, and the client will be calm. So the idea is that there's only so much like energy that a patient will have. You cannot scream forever. If you keep them in there with a phobia, they eventually would run out. Unknown there, body drains as resources usually within 20 minutes. After this point, we'll be relaxed. I mean, the idea is, they don't really have a choice. Excellent. Let's go with some evaluations. We do these evaluations, and then we'll take a 10-minute break. Not going to take us that long to get through this unit. We're going to be less than an hour in. Okay, evaluations, please, everyone. What have we got? We should also keep in mind that we could be asked to compare systematic sensitization and flooding. I don't know what the JVR method is, Octo. You want to help me out with that and tell me what it is? Okay, so we have some research there, a bunch of different researchers. Gilroy there. People prefer systematic desensitization, but flooding is cheaper. Good comparison there. Time-consuming element for systematic desensitization. Okay, a lot of conversations there about about the time difference between them. Okay, so we can have one comparison, and maybe we can have some general evaluations for them as well. The evaluations that I've got for the poster are an advantage for systematic desensitization. Although a lot of you talked about why systematic desensitization is more preferred, because the client controls their pace through it. They have to control their anxiety level, making it a more pleasurable experience compared to flooding. Some people putting in that people drop out of systematic desensitization, probably because there's multiple sessions, takes a long time. So that's our weakness there as well. Someone's got systematic desensitization doesn't help evolutionary phobias. I can see where you're coming from there. We might actually want to talk about phobias for like social phobias. It has a less useful. Okay. The example I've got, so systematic desensitization and flooding are more effective in treating specific phobias. The social phobias, I didn't have that evolutionary phobias, but if we're just making the assumption that phobias are due to learning theory, then we can still criticize it even with that with that assumption. Garcia Palacios that used virtual reality to treat spider phobias and was very effective in it. 83% improvement in symptoms through systematic sensitization used for virtual reality. Pretty cool. And then what we might do as a criticism is obviously both of these therapies work in the therapist's office. They might see some positive effects in the therapist's office, but unfortunately when they go into the real world, and they might start to feel overwhelmed again, and it might not necessarily be long lasting. Okay, everyone. That is phobias. This revision video won't take as long as the others. I'm fairly sure of it. It won't take us that long to get through OCD and depression. We're definitely more than halfway through. So I'm going to take a 10-minute break and get another drink. And I will see you guys there. You can take a break, get a snack or a drink, or you can catch up with the writing if that's what you're doing as well. So I'll see all of you in 10 minutes. Okay, so I've edited the break out this video. Just a quick reminder that if you've made it this far, to subscribe to my channel. It would mean a lot, especially being so close to 100k. And if you want the digital version of this poster, please grab it on my website or the entire revision book on Amazon. Let's get back to revision. Okay, everyone, good to see you again. Let's get started on the next section. So we are on depression. Actually, before we start, we've had a little bit of a break. Has anyone got any little questions for me before we jump straight back into it? Some weird questions. No ski. Not being bad. Been making this poster. Been getting a haircut. Yeah, don't do predictions, Elise. Sorry. The normal distribution curve and statistical frequency would be different for each culture because the common how common a particular behavior is will vary via culture. So it does vary. The curves would vary. Okay, yeah, no, I'm not going to give my full name, but we'll see. So can explain the red gun and knife fear thing. Yeah, so the things that actually hurt us in society. Maybe gun wasn't the best example because obviously guns are quite rare to hurt people in this country. But most people have been cut by a knife, or a paper cut hurts. Like very few people have a fear of knives. Very few people have a fear of paper. Um, so yeah, yeah, that's the issue. Um, we have like fears of like circles and stuff. Like the people have fears of like evenly spaced circles. It's pretty strange. Live streams will be up on YouTube for up until the next one is up. They'll take it down and put it in a playlist that's only accessible by patrons. I know it's kind of mean, but last year I only did it for I only did live stream for patrons. I just thought I'd give everyone 24 hours to enjoy them. If they're not, seem the right balance. I like to do a lot of things for free, but at least make it worth it for people who sign up. Okay, I think we have run out of questions. Okay, that's a really good example, though, actually, of a phobia that would have a really good reason why. Okay, let's do this, everyone. Let's get into this. I think I've burnt out all the questions that you had. Okay. Michael, you'll follow the link in the bottom right corner of the screen. It'll take you there. I don't want to spend more people's time talking about it, though. So let's talk about fundamentally, everyone. If we're talking about depression and we're taking a cognitive approach, in as few words as possible, what is depression all about according to the cognitive approach? Okay, let's focus on the chat now. Yeah, there we go. Fundamentally, we're going to sum up all of depression to basically one sentence for this area. Cognitive approach depression is due to irrational thoughts. Okay, so there's two elements to this that we need to know for the AO1. First of all is Beck's negative triad. So please tell me what Beck's negative triad is. People are fast off the mark for this. So Kara was already in there with Beck's negative triad before I even asked for it. So 3 negative schemas with an automatic negative bias. And we've got the self, the world, and the future. So let's reveal that. Beck's negative triad, 3 schemas of automatic negative bias, the world, the self, and the future. And that provides and that produces cognitive distortions. Okay. Let's go, everyone, then. Good work for everyone else who managed to get it out there before I managed to say it, which is most of you. Let's go with Alice's ABC model. What does A mean? What does B mean? What does C mean? Oh, Tabio, well done getting in there very quickly with a very good definition. So the ABC model suggests that after an activating event, people may have irrational beliefs about the event, leading to consequences, which is feelings of depression. So yeah, we're getting that the right way around. Okay, and then lots of other people are getting that the right way around. We have an activating event, a belief, which can be rational or irrational, and consequence. There's a rational beliefs, however, is what we're interested in when it comes to depression, because they will lead to negative consequences. Another little side term that you may or may not have, careful how you say this, is masturbatory thinking. The idea that the world must be a certain way, and that thinking it must be a certain way and holding it to those exceptionally high standards will, of course, lead to disappointment and depression. Does it matter what order we list the negative triad? Not at all. Okay. Ouch, Ogsy, that's intense. Okay. I think we're good there. So we're looking at, 6 marks for our AO1 if we come up with an essay on depression, and we've got a few things to say there about Beck's negative triad and Elsa's ABC model, and a general understanding of what the cognitive approach thinks depression is. Let's go for some evaluations then. Positives, negatives, maybe just do one each, and I'll pick up on them in the comments. Don't need to bullet point a bunch of them, just do one, and then throw them at me. Okay, you're already in there with some treatments. Maybe just stick out of those for a second. So yeah, there's a good evaluation there from Tavia. Some research suggests that depression are just more realistic. One thing that I haven't gone into is the idea that the rest of us are walking around with rose-tinted glasses, which is an interesting perspective. So the rest of us are the ones with the irrational beliefs, because life is pain. It ignores the biological influence, of course. We've got a definition which is based on a particular perspective. We can use an alternate perspective. That's a good one. Elise? Okay. There's some good ones there. Lily, I've not heard of that. ABC model doesn't account for relative depression without a cause. And we've got Grizzoli and Terry, which I will use. And we've got March as well. So I'll go into that in detail when I read it out. Okay. Really good examples there, everyone. I'll reveal mine and see if we've got some similar ones. You fill it out on the poster if you're filling it out along with me. So we've got Grizzoli and Terry, which seems to come up on a lot of mark schemes. Women with negative thinking styles, so which were tested, were more likely to develop postpartum depression after giving birth. So just a bit of a correlational study there, which seems to go along with the theory. Here's one that is linked to some of the issues that you guys had with not explaining all types of depression. We can talk about bipolar depression. So relatively common form of depression. But the manic phases include happiness and excitement. Now, we would argue that schemas are long-lasting and difficult to change, so it's very hard to explain depression about bipolar depression with as due to schemas, as there's such a quick switch between the two of them. So yeah, an interesting weakness there. March has got CBT effectiveness rate of 81%. So if, again, I point this out for the phobias, but I'll point it again for depression now. If our treatment works, that is a suggestion that the underlying theory that it is based on is valid, and that's what we're going to try and stick on there with our definition. And it could be, as I mentioned, that depression isn't irrational, but a reasonable response to challenges like poverty. Okay. We don't need to know multiple types of depression. We can just talk about depression in general. The bipolar thing I just wanted to use as a evaluation there. You don't need to use it as an evaluation. You can use other ones. But the evaluation's not any of them are need to knows really. although it's good to stick, maybe we can, to the ones that have been in mark schemes a lot. Okay. Let's go on then, because I think we've covered every one that you guys used. Let's go on to treatments. So for treatment, let's go and start with Beck's CBT. What makes Beck's CBT distinctive? Okay. Postpartum means after they've given birth. Okay, so let's keep the chat to the topic. Zana getting in there quickly with a large definition. Patient as scientist as an element. About them testing and generating their hypotheses about the validity of their rational thoughts. Reality testing from Rosie. It's a good term to use. Okay, a lot of people, patient as scientist. Okay. Some confusion there with Alice's REBT. So let's just try and keep that tight, because we want to be sure to make a distinction between them. We can start off though by saying that treatments, fundamentally what both of them are doing is challenging irrational thoughts, and we're going to try to what is known as cognitively restructure those irrational thoughts. So principle both of them based on, but they do it slightly differently. And you're right, Beck's CBT was as the patient as a scientist. So they are generating hypotheses about thoughts. They are thought catching. So they are, as they are having irrational thoughts in the day, they'll catch them and they'll write them down. And there are set homework tasks as well. Okay, that was good for Beck's CBT. Let's go in for Ellis's REBT. What is separate for that? Susie, you said you don't understand masturbatory thinking from before. This is the idea of you live your life with really, really high standards, kind of in art. Let's say you have a party planned, and then you go, oh, these people must turn up to my party, otherwise I won't be happy. And it can't rain on my party, or say it's a wedding, for example. Like you have all these musts, these must happen, otherwise I won't be happy. You'll be fundamentally let down, because life is, often disappointing, and it can't always be perfect. So basically, it's an argument to, Elsa's argument to lower your standards a little bit. Okay, we've got some examples there of D. Yep, is for disputing. E is the effects of disputing. Yeah, new feelings. Okay, restructured beliefs. Okay, we are good. One thing that not many people have put in, we are football, they're actually logical and empirical disputes. I might go into that a little bit because it's not been mentioned by many people, so maybe you might not know it too well. It might help. So Ellis's REBT, so it is a development of the original ABC model. Obviously, D is dispute, and we've got empirical and logical arguments. Empirical is like, do you have evidence for this? Let's say somebody says, my group of friends hate me. So what evidence do you have? Do you have access to, like, I don't know, a WhatsApp chat with like people saying that they hate you? Oh no, I just kind of feel it. So that is looking for evidence to support the logical thoughts and to the illogical thoughts. And then the logical argument would be trying to see if, well, does it make sense? Oh, my friends hate me. Well, do they call you and contact you and try to arrange for you to meet up with them? Yeah. Why would they do that if they hated you? So empirical and logical arguments are two different ways. Yeah, feel free to ask questions. That's what the chat's for. So effect is the reconstructed beliefs leading to better consequences. I hadn't seen the feelings F before, but you can have that as well. Kizzy, possibly not. Okay. But yeah, why not give it a go? Okay, I am going to move on. Yeah, you guys are giving me some good stuff there. Let's move on to the evaluation. So same as we've done previously, just throw an evaluation into the chat. I'll pick up and read out how you've said it. Okay, let's go for some evaluations. A rational thought would be an incorrect thought, so something that doesn't make sense, doesn't make logical sense. And usually in the context of depression, it would be a maladaptive, so it would be working against your best interest to have that thought. Okay, we got fiery. March found it's as good as drugs. It may not be suitable for everyone as it requires motivation, time, concentration, highly relapse rates. Good little collection there of points. Yeah, we can use March again. We can repeat our evaluation. We will, but we need to look at the subtle differences between how they're expressed. So, if we're saying that, if we say we've got an explanation, and we're going to use an evaluation that says the treatment works, we've got to loop it back and say, well, if the treatment works, that supports, that suggests that the underlying theory is correct. Make sure you get that in the evaluation. Otherwise, it might look like you're just kind of thrown it in. Oh, we've got one there from Merry Days, which is quite a deep point. Critics of CBT are saying that the client is responsible for their depression, which is victim blaming and suggesting that depression is all in the mind. So yeah, counter of that would be a biological perspective, wouldn't it? Takes a long time and is expensive, yeah. Requires a patient to attend sessions, again, comparing that to drug therapy. Economic implications by Ozzy, good term. Okay, lots of people going into the biological perspective. Okay. May not work for severe patients. Another one talking about Cotard's syndrome as well. I don't know how common that is. Yeah, so Grace coming in there, a lot of time commitment, which if someone's suffering with depression, they may not be able to commit to. So effectiveness decreases in the context of depression. Okay, good, everyone. Let's see what evaluations I've got. So I have got the March one again. I have put a little bit of detail in there as well that I didn't put on the other side of it. So suggesting that the 80% rate is the same as the drug fluoxetine. And the other point that a few of you had, severely depressed individuals struggle to engage in the demands of CBT. And we also have empowers patients to take control, unlike passive drug therapy. So that's the flip side of the point that I said before. I'm sorry, I forgot who said that one. Was it Merry Days, possibly? So we could see it as from a different perspective. Like, if you have CBT, you are in control of your own recovery in a way that you are quite passive with drug therapy. So yeah, you can take it either way. Another element as well is CBT is just really focused on the present, when actually we could argue that a lot of depression is due to trauma, and we're not attempting to resolve that, not in the way that, say, Freudian psychodynamics would do. Okay, so let's go on to our last section. We're doing pretty well, everyone. We're doing pretty well. Let's see if there's any last questions before we move into OCD. Absenteeism. I think that's just people being missing from work. So it would be an economic implication of depression if CBT works, and it reduces the amount of time that people don't spend at work, spend away from work, so it'll improve the economy. So for all of the treatments, we could talk about the treatment being effective for the economy because, you would miss work for any of these issues. Okay. So yeah, let's go into the AO1. Let's talk about we're talking about drug. No, we're going to talk about the genetic explanation. Let's talk about genes first before we get into neural. So genetic explanation. What are we going to include with genetics and OCD? So might get the percentages wrong in an exam. Try not to, but they're probably not as important as a lot of students feel they are. That's a difficult conversation. So we've got the concept of OCD being polygenetic, a good terminology there. We would have candidate genes as well. A lot of people know insert. Some conversations about. So we're going to talk about the genetic explanation. We're going to talk about the neural explanation, and obviously we're going to keep in mind the fact that these are linked. So the genes aren't separate. It isn't just because you've got the gene that you've got OCD. It's the gene's effect on the body because genes code for processes in the body. So there is a connection between these two things. 230 genes. We got that, Taylor. Okay. So I have summarized this down to the following. Genetic explanation is about inheritance. We've got care of hereditary. That would also work. So we're inheritance of the disorder. So we've got 230 candidate genes identified. So there's a range. So it's not one gene. There's a lot of potential genes that might work together. So we see the cert gene, gene 9, COMT, 5-HT1D beta gene. The cert gene itself we can point to as probably an important one, and that affects the reuptake of serotonin. We can link that then into our conversation about the neural explanation. But yeah, the disorder is likely to be polygenetic. It's likely to be involved in multiple different systems, multiple different genes causing it. Let's then go into the neural explanation. Now, neural explanation can include two things: small neural processes like neurotransmitters, then larger structures as well. So you can give me either of those things. Okay. You've got one there that I'm not talking about, Samir, but I'm not saying that you're wrong. Okay, but at least coming in there with a good definition of the worry circuit. Probably one that goes into more detail than I had space to write. Caudate nucleus in the basal ganglia suppresses minor worries from the orbital frontal cortex. When damaged, this then causes more signals to the thalamus, as doesn't dampen them, so causes compulsions. Worry circuit. You can say over 200 genes if you want. Low serotonin equals low mood from bright X up. That works. Serotonin would be linked to mood regulation. Okay. A lot of focus there on the worry circuit. Let's also dive into the serotonin system as well. So the neural explanation, low serotonin levels. The argument is that the serotonin is being removed too quickly from the synapse. So we have that might link to our perspective on drug treatments. And then, our worry circuit includes the subfrontal cortex, the basal ganglia, which includes the caudate nucleus and the thalamus. And the caudate nucleus and thalamus are all involved. This area, this structure, tends to be overactive, leading to obsessive thinking. And that's the worry circuit. Some of you not familiar with the worry circuit, I would suggest that you would know that as a thing to talk about in this essay. Okay, let's go. Let's talk first of all about genes and evaluations for genes. So what are we going to talk about for a research evaluation for the idea that OCD is genetic? Give me some research on that. I'm expecting a particular research to appear. It's a really good definition, Skeet. So if this disappears from the chat from everybody else, polygenetic means genes contribute to a disorder. Etiologically heterogeneous means different people have different genetic causes for the same disorder. Okay, and then we're into the stat evaluation here for OCD, and we are looking for, and we have concordance rates. That's where I'd expect us to go with the genetic explanation evaluations, and we can go to like kind of a double layer with this. So in the stat talks about dizygotic twins having a 31% concordance rate for OCD and monozygotic 68%. Now OCD is quite a rare disorder, so for it to be that high suggests there's a biological element to the disorder. We'd expect dizygotic and monozygotic to have similar living experiences, so for it to be so much higher with OCD, that would be highly indicating that there's a biological element. But we can also follow on from that to say, well, it's not like eye color, which has a 100% concordance rate. It's 68%, so that does suggest that OCD must, in some way at least, be influenced by environmental factors. So we can see there must be a combination. Now, on that point about a combination, what argument can we then bring in to talk about the combination between genetics and the environment? Okay, and we already have some people there with diaphysis stress response, which is good. Maybe we can define it as well. So Jeshen, we're going to talk about interactionalist and diaphysis stress. Okay, everyone's coming in there with the concept. I'll reveal the final evaluations for this section now. We'll go into it. Oops. There we go. Okay. So we've got diaphysis stress. This is a combination of genetic vulnerability. So the genetic vulnerabilities that we talked about above, which are the diaphysis, with the environment. So generally we'll be talking about trauma as the stressor. So we need the combination of both for it to develop. So Clotang, caused by trauma and stress, reach certain threshold for OCD to occur. Okay, and then we have supporting that idea of diaphysis stress. Chroma, 54% of participants with OCD reported a traumatic life event. Now, always wanting to use evaluations in multiple places. We've done this with each of the other sections, so we can do it again. If the treatment works and the treatment is working on the process explained by the explanation, the fact that the treatment is effective is suggesting that the explanation is effective. People are already getting into evaluations for the next section. Not don't need that just yet. So tomorrow, meta-analysis, SSRIs are more effective than placebo. So because they're more effective than placebo, that suggests there must be some biological factor to OCD. Which, these SSRIs work in the serotonin system, so it does suggest the serotonin system has a part to play for OCD. All right, let's go on then to our very last section. So we will get this done within 2 hours of going live. How important is it to know researchers' names for AO3? Again, know them if you can, but not massively important. What they did, what they found, and what that means is the most important element. Okay. Let's go OCD AO1 for SSRIs. What are SSRIs? Give me a description of how they work. We don't need to know dates for researchers, not really, unless you're going to talk about temporal validity. Yeah, there could be 316 markers in one paper. In fact, the highly likely will be. Fascinating. Yes, treatment SSRIs prevent reabsorption of serotonin. So block serotonin. Hopefully you all know what SSRIs stand for. Selective serotonin reuptake inhibitor. If you read it out, they only work on serotonin, and the reuptake of serotonin, the presynaptic neuron, is inhibited. Okay. And then if we potentially, here we go. So SSRIs, they're a type of antidepressants, and their example is fluoxetine, or also known as Prozac. So we do want to know that word, selective serotonin reuptake inhibitors. It does what it says on the tin, and it only works in the serotonin system and slows reuptake in the synapse, lowering anxiety. And then what we might want to argue, if we're going to link this both to neurotransmitters, but also the larger structure, what this is supposed to be doing is normalizing activity in the worry circuit. Okay, let's go on to other treatments. What other drug therapies are there beyond SSRIs? Maybe if someone is resistant to SSRIs, what are they going to use? Okay, we've got tricyclics there that we'll be talking about. SNRIs as well. Benzodiazepines as well. Okay, so yeah, we're going to have a little bit of things to say. We're going to focus our conversation around SSRIs, but we might want to say, if people are resistant to SSRIs, they don't have as much of an effect. They might be given other treatments. So benzodiazepines work on a different neural system, which is the GABA system. It enhances the activity of GABA, so slowing the central nervous system, which results in general relaxation. Tricyclics and SNRIs work on multiple neurotransmitters, so they're not selective, which, as a bunch of you have said, they're effective, but they also increase side effects. Okay. Let's go on, everyone, to the evaluations. So please, we have 4 evaluations I'm going to go through. Everybody, please give me your best evaluation. What were you going to include to evaluate OCD drug therapies as a treatment? file drawer effect is a good evaluation to use. I'm not going to go into that, but if you know to talk about, well, actually, a lot of negative, a lot of studies that don't find an effect are not published, so it gives a biased opinion of how effective the drug is. Limitation can cause unwanted side effects. Yeah, obviously serotonin is active in many areas of the brain. Cost effectiveness is a good point to make. Not cure, just dealing with symptoms. Okay, some good examples there in the comments, everyone. 4 months to see an improvement. This is a good point I didn't have space to go into. It seems like the drugs are active in the synapse almost immediately, but it does take weeks for the improvement to be found. Okay, everyone, here are the evaluations I've got if you want to use this to fill in your poster or your sheet of paper. So we're going to go back to the Samaro study. I've got a little bit more detail to say it was 17 studies. And we've got SSRI significantly reduce the symptoms compared to placebos. And we're looking at between 6 to 17 weeks post-treatment that we see that effect. Many clinical trials show the effectiveness of drugs are funded by the companies, showing the effectiveness of drugs are funded by the companies that created them bias. So we had a good write-up from Grace, Limitation, Goldacre. Most research studies on drug therapies are conducted by the pharmaceutical companies that created them. This means the companies have a financial gain in the drug's effectiveness. Okay. Yeah, high relapse rate went off the drugs as well as an issue. Okay, and then we have drug therapy is relatively inexpensive. So it is more convenient compared to CBT. Because you have to have multiple sessions with a trained therapist, whereas for this you just need to be prescribed them by your doctor. And then we have a final evaluations, which is often patients do prefer CBT over drugs, and that's often because of the side effects. So nausea, headaches, and insomnia are some examples of side effects. All right, so the 200 of you that's still on the chat, I wonder how many of you are here for the whole 2 hours or so, but this was a much quicker one than usual, much quicker. It did take us 3 hours. I had the live running for half an hour before I even started, so it's less than 2 hours, this one. Yeah, that is our poster completed. So yeah, I'll stick around for a second if anyone wants to ask any random questions before we finish off. Well done if you've made it through. Cool. Yeah, quite a lot of you making it all the way through. Other people just dipping in and out. Yeah, I guess selective attention is when we would focus our attention on certain things that we cause a trigger to the obsession, whereas hypervigilance, I guess, would be a more generalized, not an inability to calm down. Thanks. You have a good evening as well, Amani. So many of you here for the whole time. The majority of the 200 of you being the whole time. Okay, that's really useful for me. Yeah. If anyone ever does see like mistakes and stuff that goes in and stuff that I do, please do email me. It does make my stuff better, and over the course of the years I've done this, lots of things that have been approved has been due to students. Okay, so I think I doubt I'm going to have the memory live stream ready for tomorrow because the poster is less than half done. It does take me a fair number of hours to do, and I'm busy during the day. So likelihood is tomorrow night, I'm going to be finishing the memory poster. If anyone's on the Patreon Discord, I'll probably be on there completing it. So people ask me questions in there, and then I'll likely go live with memory now on the morning of the 15th. I don't cover eating behavior. It's a bit niche, and it's not something I've ever done in the classroom. I might try and do it this year, but there's no guarantee in that week. Okay, guys, I think that's me done. Have a really good night. I'll cover some of the other units in the future. Stay peeled for the announcements on YouTube. Not sure, Mary, days what time on the 15th, because I might still be finishing off in the morning. So let's say probably midday, 1 p.m.-ish. Okay. Okay. Thanks very much, everyone. I will, before I go to bed, I'll upload this digital file after I've fixed the evaluations in the statistical and frequency section. So just give me half an hour before you check to see if it's online on the Patreon. Thanks, everyone. Good night. So I hope that revision video was really useful for you. Just a reminder, I'm going to be doing some more of these over the course of the year, so do subscribe if you haven't already. And of course, you can get this digital version over on my website. I'll see you in the next one.